Let me introduce my team. Sincerely on behalf of Professor Shaoliang Chen. Our team on my right side is Dr. Kong Xiangquan and Dr. Zhu Jianchen. And also today's echocardiography is Dr. Zhang Juan. So today's live case is aortic stenosis case. We will treat this case with a TAVI procedure. So first, let me introduce clinical information of the patient. This is a 76-year-old gentleman presented with exertional dyspnea for 1 month. This patient has essential hypertension and TIA. So after admitted, you can see the BNP is a little elevated with a normal renal function, and also ECG show is normal. ASIC score after calculated was 4%. It's a moderate. So clinical diagnosis for this patient after echocardiography, it's a typical severe aortic stenosis. Let me show you the echocardiography of the baseline situation. So you can see it's a four-chamber view, severe aortic stenosis, and also with a moderate aortic regurgitation. So the maximum velocity of aortic valve is 5.1 meter per second. The mean gradient is nearly 60 millimeter mercury. So it's a typical severe aortic stenosis. And also you can see PHT is 318. So it's also accompanied with a moderate aortic regurgitation. And also you can see the LV function is normal. EF was 68% with a dilated LV chamber. LV IDD is 55 millimeter, and also with minor pulmonary artery hypertension, 42 millimercury. So before a decision, we also do the CT analysis for this patient. You can see from the CT analysis, it's a typical type 1 bicuspid aortic valve with left and the right cuspid fusion. You can also notice the leaflet of the non-coronary cusp. There is a calcification, but the volume is only 168. So it's a minor calcification. And also the most important parameter of the CT analysis is the annular area is 377. So accordingly, I think decision made to select the 23 millimeter for Sapien 3 valve. And also LVOT 4 millimeter below the aneurysm, the area was 361. There is no severe, there is not so much calcified. So in terms of a coronary obstruction risk, you can see the left coronary high is 40 millimeter, right coronary high is 60 millimeter. It's high enough, and also the sinus is also large than, bigger than 27. In terms of the STG, mean diameter is 25 and the high is 18, not so big. So we use a circle method. So after method, the decision made to select 26 millimeter Sapien 3 valve for this particular case. Considering there is no severe calcified lesion, so we try to direct without a balloon angioplasty, so direct standing for this patient. But another problem is for this patient is peripheral artery disease. You can see both left and the right iliac and femoral arteries, there were severe lesions. The minimal lumen area of the right iliac artery only 2.7 millimeter. Left side is also 3.2. So for this patient, actually is although there is severe narrowing, but not so calcified. So our after hard team discussion, we still prefer from the femoral approach, but we should do the balloon angioplasty before we insert the E-sheath. Finally, for this particular case, our procedure strategy is general anesthesia with TE guidance. We will select the right femoral approach. Of course, before we inserting the E-sheath, we will do the angioplasty for the right iliac artery disease, then insert the sheath, then do the TAVI procedure. with a 23 millimeter Sapien 3 for this particular case. So actually, we have performed the peripheral artery angioplasty for the right iliac artery. Let me show you what we have done now. So firstly, we puncture with a micropuncture from the right femoral. Then we insert the ProGlide to ProGlide suture device. Then do the aortic angiogram. You can see both the left and the right iliac artery, there were severe narrowing. Then also you can notice the right iliac inner artery were totally occluded with the collateral supply from the abdominal aortic artery. From the DSA, we can see there is multiple lesions at the right iliac and the femoral artery. So decision was made to perform angioplasty for the right iliac artery disease with a 6 millimeter peripheral balloon. You can see it's a longer balloon. Diameter is a 6 millimeter. Long time inflation, maintain 3 minutes. The balloon, the shape of the balloon dilation, you can see it's a totally expansion. So it's not so calcified. So long time inflation reduce the risk of the dissection. Then next, after successfully balloon angioplasty for the right iliac artery, we successfully insert the E-sheath 14 French the E-sheath. You can see there is no resistance. So this is what we have done now.
Thank you, Professor Zhang. Thank you for introduction. This is very complex with very challenging peripheral artery access. Professor Zhang, please introduce your baseline TE information.
From the TE, this is a short axis view of the valve. So a concordance with the TTE and CT, we can see actually is a typically bicuspid aortic valve with right coronary and left coronary fusion, and we can see there is a quite calcified raphe between them, and the movement of the leaflet is quite reduced, with there is a large volume of calcification in the edge of the leaflets, and the opening direction of the aortic valve is about 1 and 7 o'clock. And this can more clearly using the 3D TEE and confirm that this is a type 1 bicuspid aortic valve with calcified leaflet and calcified raphe. And all this indicated the high risk of perivalvular regurgitation after the valve deployment. We also calculate the annular area is about 3.5 centimeters square, and the area function is quite preserved. But actually, from the long axis view of the valve, we can also see there is at least moderate or moderate to severe aortic valve regurgitation. Thank you.
Okay, thank you, Professor Zhang. Thank you for your introduction with the TE information. And we just, the Professor Zhang has crossed the stenotic wall and while in the left ventricle. Professor Zhang, what's the next step?
So you can see we successfully with a straight wire cross the severe aortic valve into the LV. Then we exchange it with a pigtail. So next, I think we will use a pre-shaped wire as a support wire for facilitate advance the Sapien 3 valve.
Okay, Professor, I know you choose Sapien 3. And do you think what's the advantage of Sapien 3 compared with self-expanding valve?
Yeah, I think it's a totally two different valve, maybe suitable for different scenario for the aortic stenosis. For a balloon expanded valve, I think there is some advantage, like especially for younger patient and a low risk patient. In terms, it's a short frame, so there will be easy coronary access compared with the self-expand valve. This is the first advantage. The second is, I think there is a lower rate of PVR and a lower rate of pacemaker implantation after valve implantation compared with the self-expand valve.
Professor, what's your next step?
Okay, now I think we are all ready. We have set up our railway, so we are ready to insert the valve, Sapien 3 valve. For this, according to the CT analysis and the circular method, so we decided to use a 23 millimeter Sapien 3 valve with the normal fillings. Now it's ready. We have loaded the balloon into the valve. Okay. Okay, please go to the aortic LAO projection. Hold the wire. Okay, good. Hold the wire. Okay, good. I flex the valve tube. Okay, good. Let's go to the Copeland view. LAO 12 degree. Good. Good position. Yeah. Okay, so we are ready to implantation. 准备好了吗? Okay, pacing. 118. Okay, ready. Pacing. 打起来. Pacing. Good. Nice. 1, 2, 3, 4, 5. Down. Okay, stop pacing. Good.
Very stable.
Okay. I think it's good.
Yeah, only mild, maybe PVL or regurgitation. Mild.
The position is good.
Yeah.
I don't think there is PVR. It's central.
There's almost no PVR.
Okay.
Yeah, I think
and
so.
the position is good.
This
And
is
the
good.
valve is working well.
Okay.
The situation is good. There's no PVR, and the transvalvular velocity, the mean pressure gradient is all very perfect. Yeah.
Okay, actually you can see from the thermodynamic, actually there is no gradient. So pressure a little high, I think, yeah, we can lower the pressure. Please, my anesthesia colleague, please lower a little pressure for this patient. So finally, I think it's a good result after Sapien 3 implantation for this particular case. And there is no PVR, and the maximum velocity only 1.3 millimeter. The mean gradient only 3 millimeter. It's a perfect result without injury the coronary access. I would like to finish the case, and the next step I would like to treat to do the angiogram for this patient's right iliac artery. When we move out to the E-sheath to see is there any severe dissection or is there any flow limited dissection. If there severe dissection, there is no flow limited, and also there is a radial stenosis less than 50%, I will just leave it. If there is a flow limited dissection or still there is a severe radial stenosis more than 50, maybe I will put a graft stent for this case, for this right iliac artery disease.
Okay, Professor Zhang, what's for this 76-year-old gentleman, what's your antithrombotic strategy after the TAVI procedure?
I think for this particular case, a single antiplatelet therapy with aspirin is enough. because this patient is a size arrhythmia. According to the guideline, I think lifelong antiplatelet therapy with aspirin is our recommendation for this patient.
What do you think? What's the risk of coronary occlusion about this patient?
For this particular case, I think there is extremely low risk of coronary obstruction for the TAVI procedure. I think the valve, according to the sinus, I think is big enough for the Sapien 23 millimeter valve. This is first point. Second is the coronary high. Both left and the right coronary high is higher than 15 millimeter. And also the leaflet, actually, both left and the right corner leaflet is not so, there is no big calcium nodule at the leaflet tip. So after valve implantation, I think there is no risk of coronary obstruction. Also, you can see after procedure, we do the coronary aortic root angiogram, the flow, both air left main and the RCA is totally very good. There is no injury. Yeah, from the conrectal artery, left iliac artery, Dr. Kong insert another pigtail at the aortic to do the aortic angiogram. Yeah, when we pull out the sheath to do the angiogram from the conrectal side to confirm there is a injury of the right iliac arteries.
Professor Zhang, your team has a great experience at dealing with this very challenging peripheral artery. And my question is, what's your backup strategy if we failed to insert the issues?
Actually, for this particular case, I'm not worried we will fail to insert the issues. Although there is severe narrowing, but actually there is no severe calcification. So we were sure, we will anticipate we will successfully gradually dilation. We will use a 6 millimeter balloon to dilate first. If successfully the balloon is fully dilatable, I think we can successfully insert the French 14 French sheaths. On the another hand, if there is a severe calcification lesions, which means undilatable, for this scenario, we will use shockwave. Yeah.
Okay.
Similar to coronary artery disease, therapy with IVL will facilitate the lesion prepare. After successfully lesion prepare, we still can insert the sheath. Yeah. Okay. Of course, after procedure, there is gentle. There, be careful. There is dissection. Be careful. Yeah. Now it's good. Always make the guiding catheter tip coaxial.
We'll pull back the issues.
Since there is no severe dissection, there is flow is good. There is no flow limited dissection. We can take a picture now.
Yeah. Okay.
我看一下，对，好 ，OK。
Ready? Yes, looks good.
I think it's a type B dissection. What do you think? Stand. Yeah, it's a type B dissection without flow limited. Yeah. I think we can leave it. Yeah. Okay, good.
Okay, now I will pull out the issues.
Okay.
Do
close the puncture site.
budget.
Okay. We'll put two pull glide at the femoral puncture site. See the beautiful of the Sapien 3 TAVI procedures. I think the low profile for the issues only 14 French. So, which means with associated lower rate of peripheral artery complication after procedure. This is an elderly gentleman, more than 76 years old, presented with heart failures. Echocardiography show severe aortic stenosis with BAV. It's a typical type 1 BAV, and according to the CT analysis, so decision was made to select the 23 millimeter Sapien 3 valve. Before we input the inserted the issues. We do the balloon angioplasty with a 6 mm balloon. After successfully lesion prepare, we inserted the 40 French issues. Then stepwise, we insert the wire and advance the 23 mm valve, and with a nominal position, we successfully deployed the valve. After deployment, the echocardiography and also the angiogram shows there is no PV error, and the hemodynamic parameter show good result with median gradient only 3 mm mercury. So we successfully remove the sheets, and the angiogram shows there is only a type B dissection without limited anterior flow. So we just decided to leave it with medicine therapy. So this is our case. So ladies and gentlemen, thanks very much for your observation. Sincerely on behalf of Professor Shaoliang Chen, really appreciate your invitation and participation. Thank you.